In previous pearls, we've discussed the literature to support using ultrasound to confirm endotracheal intubation, and today I'd like to show you how to perform that technique. There are a couple benefits to using ultrasound during intubation. The first is that it's just very easy to do. The intubator is at the head of the bed, and you're off to the side. You're not in anyone's way, and the amount of pressure it takes to visualize the trachea does not distort the airway anatomy. Next is how fast you can detect an esophageal intubation. If you see the tube going into the esophagus, you instantly know that this is an incorrect placement. Compare this to not knowing where the tube is and connecting the end tidal CO2. So if you see the tube going right into the esophagus, there's no need to even connect the CO2 detector, just remove the tube and attempt again. Finally, I find this technique to be useful as a supervisor when others are doing intubations. Typically, there's not much I can do when I'm standing at the side of the bed except annoy the residents by saying, "What do you see? Do you see the cords? Where are you at?" By using ultrasound, I can quote unquote look as they're looking, and I can see where the tube is going even when they can't. So what we're going to do is we're going to take our linear array probe with the marker pointed towards our left or the patient's right and come just off the midline as shown here. And what we want to identify is the trachea and the esophagus. In this cross-sectional cartoon, we see our trachea is anterior, shown by the yellow arrow, and our esophagus, more oval shaped and muscular, is posterior as shown by the purple arrow. And here we see a clip of our esophagus and our trachea. You see the esophagus has concentric rings, smaller than the trachea, and oval shaped. And you see our more circular trachea here. These are the landmarks we're going to look for when using this technique to confirm endotracheal intubation. And here we have our esophagus and our trachea, and watch what happens during intubation. Keep your eye on the esophagus, and as the tube is advanced, you notice that something's happening to the esophagus. And here we actually have two tracheas. Watch again. You'll see our esophagus and our trachea, and you'll notice as the tube is advanced that now we have two tracheas. And I say two tracheas because now we have one tube that's in the esophagus and our trachea remains the same. So this is an esophageal intubation. Now we remove the tube and try again identifying our esophagus and our trachea. And we're going to keep our eye on our esophagus as the tube is advanced, and we see that there's movement, but we never see the esophagus dilating as we did in the previous slide. We're still going to hook up our end tidal CO2 to confirm, but in this case, this was correct endotracheal placement. So in summary, we're going to use our linear array probe with the marker pointed towards the left as we normally do in emergency ultrasound. We're going to go lateral just off the midline to the patient's left or our right, and we want to identify the esophagus, our key structure that we're going to be watching during the intubation. So on your next shift, I recommend taking your linear probe when you're using it for other things such as lung sliding and start to identify this anatomy so that when you get good at it, you can take it to your next intubation and use it during the procedure. Take some clips, feel free to send them to me, or just let me know what you think about this procedure and any comments, whether it's on Twitter or by email. Thanks for listening, and talk to you soon.